And it's sharp 9:30 p.m. Riyadh time, so we can start formal with this webinar. Dear all SESME members and participants, Assalamu alaikum and good afternoon and very warm welcome to this webinar arranged by Saudi Society of Medical Education, Riyadh Office Journal Club. I'm Dr. Shazia Iqbal, chairperson and organizer for Continue Professional Development Activities at Saudi Society for Medical Education. Our society is very much keen to enhance the teaching and assessment capabilities of medical faculty. We believe that assessment has a powerful positive steering effect on learning and the curriculum. We value assessment as the most powerful motivator of student learning. Therefore, we trust that the assessment process must be purpose-driven and meaningful. And this is our fourth webinar by SESME to accomplish our goal. The purpose of today's Journal Club session is to focus on programmatic assessment. What is the underlying learning concept and theory? We shall learn that how programmatic assessment is an integral approach to design of an assessment program with an intent to optimize the learning process, and how programmatic assessment for learning can be applied during training programs. So the topic of presentation is programmatic assessment, and I'm honored and delighted to present a distinguished speaker, Dr. Kees van der Vleuten. Very warm welcome, Dr. Kees, to SESME Riyadh office.
Thank you very, very much for this introduction.
Dr. Kees, let me introduce about Dr. Kees more. Dr. Kees van der Vleuten has been at University of Maastricht in Netherlands since 1982. In 1996, he was appointed as Professor of Education and Chair of Department of Education Development and Research in the Faculty of Health Science and Life Sciences. Since 2005, he has been the Scientific Director of the School of Health Professions Education until September 2020. This graduate school offers master's and PhD degrees in health sciences education to a wide variety of international students. He mentors many researchers in medical education and has supervised approximately 90 doctoral graduate students. His primary expertise lies in evaluation and assessment. He has published widely in this domain, holds numerous academic awards, including several career awards. In 2005, he received John Hubbard Award of Significant Contribution to Research and Development of Assessment of Medical Competencies from National Board of Medical Examiners in the US. In 2010, he received the Dutch Royal Decoration for societal impact of his work, and in 2012, the Karolinska Prize for Research in Medical Education. He serves frequently as a consultant internationally. He holds honorary academic appointments in School of Medicine, Flinders University, Adelaide in Australia, University of Witwatersrand, Johannesburg in South Africa, and University of California, San Francisco in the USA. He is also director of European Board of Medical Assessors. So very warm welcome again, Dr. Kees, to SESME Riyadh office, Saudi Arabia. Well, before we begin, I would request Prof. Khalid bin Abdurrahman, President, SESME Riyadh office, to give some opening remarks.
Thank you, Dr. Shazia. Again, I would like to welcome Professor Kees. He is one of my best and old friends, and we shared a lot of active engagement in the development of medical education internationally. So I am so happy that Kees again returned back to Saudi Arabia. Of course, in distance, although he is so familiar with Saudi Arabia development in the field of medical education, especially when he was engaged in the School of Medicine in Al Qasim and King Saud University. And he also join us in our CIMIC International Conference in Medical Education 2012. So again, Professor Case, he will talk about very, very unique and topical subject in the field of medical education, where the movement and the shift from assessment of learning to assessment for learning. And we would like to hear from Professor Case this topic. And we are also welcome questions and remarks after his talk. Please.
Yeah, thank you very much. Yes, Dr. Keys, you can start, please.
Okay, thank you very much for this warm introduction. It's good to be back in Saudi Arabia again, although this time virtually. But thank you very much for the invitation for the for this evening and for the Saudi Society for Medical Education. I'm honored. Yes, I'm going to talk about programmatic assessment, but I'm going to take you on a journey. And basically, that has been my personal journey, really, through assessment in my life. I've been in medical education for a long time. I've been working in a problem-based medical school for a long time. I've been engaged with research in medical education for a long time, and I've seen a lot of developments in various areas, but tonight we're going to talk about assessment. So I'm going to take you on this journey. It's a journey in a helicopter, you know. I'm looking at it from a distance. I won't go into very nitty-gritty things, but I'll take a distant perspective, and I'll take you the journey towards what has shaped my view around assessment and ultimately developed into programmatic assessment. This is the overview of my presentation. I will look at educational practice and then look at the consistencies of the research that has been found. And then from that research, and the messages from that research, I'll turn into an assessment theory. And from that theory, I go back to practice. I will give you an example of a practice where programmatic assessment is applied. And then from practice back to research again. What is the research on programmatic assessment at the moment has to say? And then finally, I'll come to some conclusions. The toolbox in medical education is well filled. We have a lot of instruments. And in the past, we've been organizing this using Miller's pyramid, which has been a very useful, simple model of competence. With at the bottom, we have knowledge assessments with multiple choices or write-ins or oral examinations. And then we apply that knowledge into clinical problems. We assess clinical reasoning. And again, there's a lot of development there, scenario-based, case-based items and assessments that have been developed. The showing how, I don't need to tell you how popular OSCEs are. Probably every medical school in the world, including Saudi Arabia, probably uses the OSCEs. But I think in the last 10, 15 years, there's been a lot more attention to performance assessment in vivo in the real world at the DOS level. Now we can look at all these instruments and compare their quality characteristics, right? For time reasons, I will focus only on these three. Validity, what are we measuring? Reliability, are we measuring precisely? Educational impact, what's the effect of the assessment on the educational process and on the learning of the students? Validity, let's start with that. Look at what we're assessing, things are changing. I mean, if we look at curricula, they have changed from an input orientation to an output orientation. Input orientation means so many hours of anatomy, so many hours of a particular discipline, so many weeks in this particular clinical rotation. We all started to formulate the output, what learners should be able to do at the end of educational training programs. And so we started to formulate generic competencies, and I'll come back to that later on. And we went from teacher-oriented programs to learning-oriented, self-directed programs. So the didactics of the educational process has been changing as well. In many modern training programs, there's a lot of emphasis on self-directed learning as a basis for lifelong learning. So actually, that's also what we want to measure. And if we look at the world, then the whole world is developing competency frameworks. And here are 3 of them. And I understand Saudi Arabia has its own competency framework. And these competency frameworks are developed with a lot of stakeholder input, so that it really covers the sort of skills that people need to have for modern medicine. And when we compare these different competency frameworks, then a couple of things do strike me. First of all, most of the competencies are non-technical skills, are skills that are complex. I mean, try and define professionalism or communication skills or systems-based practice. That's not easy, yet they're very important, because we know from research that if things go wrong in actual practice, in actual clinical practice, these kind of skills are involved, much more than the theoretical knowledge. So these are complex skills that are also learned by doing, not by in a book or something. You have to learn these kind of skills by doing them and getting feedback on it. These are complex skills that do not develop overnight. So you can't have a course, let's say, on communication, and then have sort of an exam at the end, an OSCE, for example, and then you're a good communicator. It doesn't work that way. So typically, these kind of outcomes are your longitudinal strands in a curriculum. And you pay attention to all of those competencies during the whole curriculum. And people learn by doing these complex skills and by getting feedback on it. So that's quite interesting, I think, that these systems are so similar to each other. These complex skills are essentially behavioral. You learn them by doing, and essentially they are behavioral. So basically, you can only assess them in the top of Miller's pyramid, or best assess them in the top of Miller's pyramid, which is interesting because they have to be assessed through judgment. They cannot be easily standardized into a standardized test. They need to be carried out in actual practice, need to be observed, need to be judged, requiring professional judgment. Now, what we then need to do if we wish to assess these complex skills, we need to assess them with unstandardized assessment technology. And the question is, how do we do that? And isn't that very subjective? And I'll come back to the issue of subjectivity. But what are the messages that come from the validity research? Well, first and foremost, there's no single method that can do it all. There's no magical bullet. And I have been part in the history of developing many of those instruments. And every time we were excited, now we have the best instrument to assess something. And then later on, we discovered it was only a part of the whole total message. And I still think, for example, that people think that the OSCE is the holy grail in assessment. Well, the OSCE only assesses in a standardized way, and doesn't capture all those complex skills. There's no single magical method or bullet. And in order to do a good job, we need to have a mixture of methods to cover the entire competency pyramid. The second message is that we need both the standardized and non-standardized assessment methods. If you only have a curriculum that is using purely standardized assessment methods, you'll miss out some of the competencies. An important message, I think, is that for assessment, for standardized assessment, like in written testing, like in OSCEs, some quality control around test development and administration is absolutely essential for the validity of what you're measuring. And medical schools are being pushed to develop those quality control, that quality control around test development and test administration. For example, in review panels, looking at questions or OSCE stations or whatever, before the test is being administered. And that has a profound effect on the quality of your test material. Finally, what we've learned is that in unstandardized assessment, the users of the instrument are more important than the instrument itself. If we talk about observing a clinical encounter and we wish to give feedback to the individual learner, then the way the feedback is being carried out and the way the interaction takes place, the way the dialogue takes place between the assessor and the learner is essential. And the quality of that interaction is really essential for the validity of what you're measuring, much more than whether you have the right checklist or not. Right, if we move from validity to reliability, we talk about precision. And we can actually estimate, calculate the reliability of assessment methods. And you can compare that to measuring your length. Suppose I would measure your length and I would do it twice. I would expect a high correlation between the first measure and the second measure. That is reliability. Reliability is expressed in a number between 0, no reliability at all, and 1, perfect reliability, right? And here's a slide with a study showing other studies where they published reliability estimations. And basically this ranges over Miller's pyramid with the multiple choice on the left-hand side, moving up Miller's pyramid to the right-hand side of this slide. And in the right-hand slide, for example, there are incognito simulations or standardized patients, which are sent out to doctors' practices. And these doctors didn't know they were being assessed by these simulated patients. So basically, this is very, very authentic and unobtrusive assessment of the person in place. Actually, the person who is being assessed doesn't know he or she is being assessed. Well, they say that summative testing, tests with consequences, need at least a reliability of 0.80. Now, I'll let you look at this slide, and you'll see that you quickly need quite some testing time, like 4 hours, 3 to 4 hours of testing time before your test will become reliable. Yet in other words, most of our tests in educational practice are not so reliable. Yet in other words, a single test will give you a lot of pass-fail decision errors simply because of the noise in the measurement. This is really bad news. And this has been found time and over again and has been called the content specificity problem in competence assessment. So basically, you need long testing time in order to come up with a reliable score, or be very careful with addressing high consequences to an individual assessment. Be very careful for that. This is bad news. But there's also good news in this slide. I mean, you cannot say that the more objective forms of assessment are more reliable than more subjective assessments. To give you an example, the oral exam is a very subjective form of assessment. Actually, if we look at history, the OSCE, the Objective Structured Clinical Examination, was introduced because of dissatisfaction with the subjectivity of other clinical examinations, like the long case and the oral exam. Therefore, Harden introduced the objective clinical examination, structured clinical examination. And he thought that by bringing in more objectivity, he would have more reliability, but actually that is not the case. Reliability is strongly associated with sampling, with the number of items in the test, the number of OSCE stations, with the number of mini CEXs that you do. So actually, the OSCE is not the star here in terms of reliability. And often I read papers where we see the OSCE is a very reliable approach to assessment. In itself, this is nonsense. It all depends how much you sample. So basically, a couple of messages that come from the reliability research is that acceptable reliability is only achieved with large samples, right? A lot of test elements and a lot of assessors. And that no method is inherently better than any other, right? All methods can have low reliability. All methods can have high reliability, all depending on the sampling. Because objectivity is not equal to reliability. So objective methods can have poor reliabilities, and vice versa. More subjective measures can have good reliability, all depending on the sampling. And that is good news. Because if we wish to assess those complex skills, those complex outcomes, we need to rely on judgment, on professional judgment, on subjective judgment. And we can do that provided that we sample widely. So many subjective judgments are pretty reliable. Okay, so this is the second area of messages from the reliability research. Let's move on to learning, assessment and learning. They say always assessment drives learning, right? But that relationship, how assessment drives learning, is much more complex than we think. And actually, a lot of that driving effect is negative, often promoting poor learning styles. Testing or learning for the test to pass for the test. We see a grade culture. We see competitiveness as a result of that. And we see grade inflation. I also see little information in the system. I mean, a grade, particularly if we talk about complex skills, is meaningless, right? If you were to grade me at the end of this lecture and you would give me a 7 out of a 10-point scale, well, thank you. But what should I do differently next time? The grade itself is meaningless. And actually grades are the poorest form of feedback you can get. So there's a lot of reductionism in the system, little feedback in the system. We have wonderful goals with our curriculum of developing them into self-directed learners, but I see very few elements in the assessment system back for that. I see also very few longitudinal elements. Basically, what we do in assessment in educational practice is something which is very simple. a piece of education, at the end of education, that education period, you get an assessment and you sign off that particular piece of education. Basically, if I would put that into a caricature, then this would apply to our educational practice. And it's actually true. If you are familiar with the forget curves in psychology, if you remember something for the occasion itself and study for that, 50% of that information is gone after a few weeks. So we need more longitudinal elements. I think the messages that are clear is that, in my view, there should be no assessment without some meaningful feedback. And remember that I said grades is not meaningful, are not very meaningful. And we know from quite a lot of research that narrative feedback, feedback in the form of words, has a lot more impact on complex skills than scores do. And particularly with those complex skills, we tend to think and tend in assessment to put everything in a scale, in a score, because we think it's more objective. I think that has brought us a lot of bad things. I think that particularly we talk about complex skills, words are a lot more impactful. And then we know, interestingly, that the provision of feedback is not enough for the use of feedback. And that use of feedback needs to be scaffolded, needs to have some follow-up, needs to have a dialogue created around it. And later on, I'll show you what that means for programmatic assessment. And we need more longitudinal assessment. We need to monitor how students develop over time. If we look at these outcomes are your longitudinal strands in the curriculum, and the curriculum is usually formed around these outcomes. How does the activities in the curriculum cater these outcomes? What sort of assessment activities are linked to these outcomes, and how do people develop over time? Right, so these are some important messages from the educational research around assessment. Now, using those messages, I come to programmatic assessment, right? Because basically, validity says a multitude of different methods are needed. We need a mixture of methods. Reliability says we need a lot of information. We need a lot of sampling. Be very careful with a single assessment. And the learning impact research says assessment should provide meaningful and longitudinal information for learning, much more than we do right now. And that to me is the basis for programmatic assessment. And in programmatic assessment, there are a number of principles, and I'll focus on a couple of important ones. But there are more, and they're going to be published soon in the consensus and Ottawa consensus statement. In programmatic assessment, we consider every individual assessment as but one data point. And there's a little delta, a little pyramid behind it. It could be any sort of method. It doesn't really matter. The choice of method, in my view, will depend on your educational justification for using that method at that moment in time, and how it may impact learning in a positive way. But every assessment is one data point, and every single data point is not meant to pass or fail the student. Every single data point, every single assessment is optimized for learning, meaning that feedback is being given. Hopefully information rich, either quantitative or qualitative. And I'll show you some examples later on of how we do that in my own institution. But the feedback should be meaningful, and the different data points should be varying in different formats. If you build up your curriculum, you want the assessment to have your learners write over there, verbalize over there, justify over there, and so on and so forth. So there's a mix of different approaches in the assessment. And the summative, formative distinction, I would replace by a continuum of stakes. Individual data points take no pass-fail decisions. Therefore, they are low stakes. They are low stakes because there's no sting. There's no pass-fail decision, right? If we need to take a decision about student progress and there's more at stake, then we need more data points. So the number of data points that we need are proportionally related to the stakes of the decision, right? And I'll put that into a graph. If there's a low stake assessment, then that assessment is focused on information, on feedback, on giving meaningful information to the learner. It's not decision oriented. Let's say that we have this bar represents a full year. Halfway through the year, we want to take a decision on, or at least monitor the student and look at his performance over time. And we get an intermediate progress decision. Where are you? What goes really well? What needs attention? What needs some remediation? So that the student knows where he or she stands. And then maybe at the end of the year, we need a very high stake decision. We can only do that if we have many data points, if we have a lot of information on the learner. And only then we can take a decision. By the way, that decision should be non-surprising, because if it's surprising to the learner, then something must have gone wrong in the process prior to the decision. Basically, what we do is we treat assessment information as pixels, pixels in a photograph. If you have a single pixel, you don't see a lot, right? If you add more pixels to the picture, then slowly the image is clear. And once the image is clear, when you have a lot of pixels, a lot of data points, then you can take a decision, not before that. So this is the basis for programmatic assessment. In programmatic assessment, we also aggregate information differently. Our classic approach is to aggregate within a method. So, for example, we have an OSCE, and we have a station on resuscitation, and a next station on abdominal complaints, and the next station on history taking of a child, maybe. And then we add everything up at the end, and we hold that against the passing score. And that's how we aggregate in a classical approach. In programmatic assessment, we aggregate differently. Here we aggregate information across different methods of assessment, across data points, to a particular skill or to a particular competence, right? So we may take the information from the OSCE on communication and aggregate that with information from a mini CEX on communication and aggregate that together. So this is a different way of aggregating information. Right, so this is the basis for programmatic assessment. I'll give you an example. So we move back from the theory to practice. And in the meantime, there are a lot of programs now implementing and using programmatic assessment, and I've lost track of how many programs are involved using programmatic assessment. And actually, we just published a Dutch book, unfortunately, it's not in English, on experiences with programmatic assessment in 10 different non-medical programs using programmatic assessment, and looking at some of the lessons that are learned. I'll turn to one of our own programs, which I know best. And actually, this is the place where we started programmatic assessment historically. We have a physician clinical investigator program, which is a graduate entry program. So people come in with a relevant bachelor degree, and then they become a medical doctor in 4 years' times. So, and on top of that, they get a Master of Science in clinical research. So they have to work hard to both learn medicine and learn science in 4 years. The assessment programs is assessment in modules, just like you would normally have them. They could be anything. They could be multiple choices. They could be small scale multiple choices. I know one medical school, for example, that gives an essay test every week on the content of that week, which is not graded, but given feedback on. It could be presentations, it could be assignments. So this happens all in the modules. On top of that, we have a lot of longitudinal assessment. So, for example, in the knowledge domain, we use progress tests, which is kind of a final examination that we give 4 times a year to all students in the curriculum. And we look at their progression. But we also have a lot of peer assessment, where we look at the evaluation of professional behavior, where we look at these kind of skills that we saw in the outcomes systems. And all the assessment is informative and low stake. So there's no pass-fail decision in any of these assessments. Everything is gathered into a portfolio, which is the central instrument. So the learner has an electronic portfolio, and every assessment information or other relevant information is stored into that portfolio. Here's an overview. We have several modules. We have a progress test 4 times a year. There are longitudinal assessment of knowledge, skills, and professional behavior. And then every student is connected to a mentor or a counselor, as we call them. I don't like that term at all. Counseling is something different from mentoring, but basically, this is a mentor who follows the learner through all the years in the curriculum. So you become very acquainted with a particular learner as a faculty member. And the mentors have access to the portfolio of the student. And the mentors have regular discussions with the students. Actually, the students are required to prepare the mentor meetings by analyzing their portfolio. So by looking at their performance, by analyzing what goes well, by analyzing what they need to change, that is being discussed with the mentor. At the end of the year, we take a high-stake decision, and I'll come back to that later on. We do that in a group. We pay a lot of attention to feedback. For example, this is an example of an online form of feedback on the progress test. Here you see the performance of an individual student on the various progress tests. And he starts climbing higher and higher. And actually, the computer can predict your future performance based on your past performance. And you can do that for any kind of subject matter. You can do that for your total test scores, but you can also ask, show me my anatomy scores over time and how they develop. Show me the total of all my basic sciences in a longitudinal fashion. Show me how I do on internal medicine longitudinally. So you can get really a good picture of the knowledge development of an individual learner. The electronic portfolio is also able to aggregate all the information because there's still quantitative information, usually on a 5-point scale. and the electronic portfolio is able to generate and aggregate that to an individual feedback diagram, such as this one, where you see the performance of the individual versus the cohort of students. We can also look at the assessments longitudinally over time, and we can click on any blue dot and get the assessment information behind it. So you quickly get an overview of the performance of an individual learner. One of the most important functions in the electronic portfolio is the generation of all narrative feedback on this particular learner. And then the computer generates all the narrative information that has been documented on this particular learner. It can be filtered by competency, for example. It can be filtered by feedback type. Like, for example, show me all mini CEXs. So this provides a very good picture overview of what the student is able to do. The coaching is done by counselors. As I said, I don't like that term, but it is really essential for success of reflective learning skills. So we promote self-directed learning skills by providing coaching and mentoring to the individual student. Really important. And then the decision-making is done by committees. At the end of the year, we take a high-stake decision. And we then look at all the portfolios and we discuss them if needed. Because for 90% of the students or more, this is a simple judgment. They do really well. You don't need to deliberate on those students. You don't need to spend a lot of time on those students. But for a number of students, you need to deliberate as a committee. And that's what we do. So the committee comes to a consensus judgment based on interaction with each other, based on weighing the arguments, and then they come to a decision in such a way that this is a pretty tough and robust judgment, because, you know, a group of experts looking at the performance of an individual learner, making an informed decision about progress. If you pass, then you get your credit points, all your credit points at the same time. If you fail, you can either have to do, it depends on what the problem is. If you have to repeat something, if you have to repeat the whole year, or maybe even you might be promoted provisionally to the next year, and you must remediate some elements. It all depends on the findings of the committee, what they found in the performance of the student. Right. I'm coming to the end because I'll be short on practice to research, because I want you to have some time for questions as well. There's a lot of publications nowadays on programmatic assessment. And actually, here's the last one where the rubber meets the road, is the first integrative review paper on programmatic assessment that has appeared in Perspectives on Medical Education just recently. But if you want to find some of those papers, go to my personal home website, www.caseonoflearning.com, and you'll find a number of papers there. I'm not going to discuss all these research points, but let me point to one thing. Programmatic assessment is an attractive model which convinces people, particularly if we talk about modern approaches and modern curricula. However, implementing it is a big challenge, because implementation of programmatic assessment requires the buy-in from both your staff and your students. And that's a big challenge, right? You have to work on the assessment literacy of your stakeholders. And that's a big challenge. Nevertheless, many programs do and change as a result of such a process. Some conclusions. We should stop thinking in individual assessment methods. We should think in more holistically in programmatic systems approach of assessment. And every method may be functional. Old methods, new methods, subjective methods, objective methods, they all can have a function. And we need to realize that professional judgment is imperative to assess complex skills, similar to clinical practice. And we can deal with the subjectivity around that. So actually, in my view, programmatic assessment both optimizes the learning function of assessment as well as the decision-making function of assessment. And to me, that is a good unified approach. Right. Here ends my journey. And I think it's exactly 15 minutes past the hour. And I would like to see if there are any questions.
Thank you very much, Prof. Keys, for this wonderful presentation. Yes, Prof. Khalid, you raised hand.
Thank you so much, Professor Keys. I think it's really very nice, and I actually enjoyed your journey through this interesting topic. Let me just comment on the practicality of doing such a wonderful idea of programmatic assessment. I think in our area, let's say in the Arab countries and in GCC countries, where the regulations of assessment is usually central, we have to have a grading system. We have to have a formative and summative assessment. And most of the students, and we witness this every day, they are most exam oriented. They focus on the scores, grades, and kind of assessment rather than the actual training, especially in the medical field.
Yes, Professor Khalid, but that's how we train them.
Yeah. So the idea, and if we want to apply this kind of, let's say, the holistic and focus on the assessment for learning rather than off learning, so we may combine both in our area, because we cannot totally replace the system that we have, but we can manage, we can insert this kind of new approach within the formative, within the system that we have, and we apply it in our school in yes. one way or another. And well, I found it is very good, but the problem is still the students, they are oriented more on the examination, on the grading. So what do you think? Is it possible really to merge both approaches in one system like our system?
I think that if you create a hybrid system, the summative component will always win. Mm-hmm. And you're right. Naturally, every school is functioning in a wider environment, which has certain legal procedures, which has requirements. And basically, we also had to fight the system to be able to pull this off. And we did. And I think that is important. I think that an evolutionary approach by mixing summative and formative functions, I think that's wise, but it won't produce you the best results. I've long been involved in problem-based learning and schools moving towards problem-based learning. And the best results are achieved when the implementation is more radical. Hybrid systems produce hybrid results. And I think the same goes for programmatic assessment. And I agree, it will be a challenge for you. It will also be culturally a challenge for you, because I know that the system in Saudi Arabia is still pretty hierarchical. And particularly in programmatic assessment, you need more of a flat hierarchy in which students speak up and actually show their weaknesses rather than only boosting their best results. So I think, yes, it's a challenge. That's why programmatic assessment is a nice concept, but a big challenge.
Yeah. Thank you.
Thank you. Yes, Prof. Hamza.
Good evening, everyone, and a very hot welcome for Professor Case. He's Case, not Keys. Hi, Prof. So it is very nice. So I want to correct that he's not Keys, he's Case. Yeah, and very nice to again see Professor. We always, when we talk about the assessment, we say that it is related to Professor Kess' research and his paper and so on. So really, I really enjoyed and was very excited to hear about. I have read a lot and hear a lot about that, but the things to hear from really the origin of the programmatic assessment. Again, just to add what Professor Khalid said very truly and nicely, that our system, we started including very small feedback types. So there's a lot of challenge. Our system, let me tell you that when the student, they come from the very preliminary school to the pre-med, so again, based on the grades, and then they come to the pre-med for 1 year to be selected for the medicals. Again, this is based on the grades. When they finish their graduation and they go to selected by the post-graduation, again is based on the grades. So that's the system. But there are changes are starting from being the discipline-based and content-based. Now we are looking for the outcome-based curriculum and assessment. Things are changing. But as you said, there's a lot of challenges. It's not only our system, but even just very simple skills of giving feedback. That needs a lot of work. That, we should learn that how to really construct the feedback and how a student they're going to really. Student, they said, why you have given 19.5 out of 20? No. I want full marks because I have to, I'm sure that I got full marks. And we are not able to say that why 0.5 marks was reduced. So those are the really, and it's very difficult to really change the system. Now things are coming, and I mean better. Say for example, even the university regulation that you have 60% marks for continuous assessment. But how we are using now because of this pandemic and so on, our university, KSU, they decided that continuous assessment will be 80%. And final decision only will be 20%. So how we are really utilizing these things. So that's the most important part, that how we can really adjust our this system to things which are really evidence-based, things which are really giving the student that how they're going to learn. When we sit in the clinic and when we discuss with the our student, and they say that, take a history, and when we give really feedback and what is the follow-up of that. So those are the things we started including a portfolio at the very small scale. We started giving some feedback, so on. So I think slowly we can change. There is a time to or there is a space to that we can change to this type of. We're not going to go exactly what Professor Case has included in his school, but still there are places that we can make our assessment of learning towards the assessment for learning. Thank you.
Yes, well, basically, I think you're absolutely right, Hamza. It's very hard to implement programmatic assessment as a whole. I think you have the best chance if you start something new. And I know there are many new medical schools in Saudi Arabia. And I think then you have the best chance. I mean, again, it reminds me of the problem-based learning discussion that we had so many times. People also said, this is not fit for our culture. And yes, in the beginning, it were mostly Western countries that implemented problem-based learning, but now it's all over the world. And I think the same will go for programmatic assessment. I think you see the first schools adopting programmatic assessment, particularly in the West, in Australia and in New Zealand. But I think others will follow later on.
Thank you very much. Yes, Dr. Shahid.
Good evening, everyone. Can you hear me?
Yes.
Yes.
Professor Case, thank you very much. I'm very delighted to see you today because I thoroughly enjoyed your research when I was doing my PhD, and I put a lot of research that you have done in my PhD thesis. So it was the foundation, and I'm very delighted to see you. And thank you very much for giving us once again a very delighted talk. Enjoyed thoroughly. Couple of questions. Now, in your reliability slide, you mentioned about the time. If you increase from 1 hour to 2 to 3 to 4. And if you look at different methods of assessment from MCQs to OSCE to other things, there is an increase. Would you please help us in learning that the amount of the efforts needed to increase the test duration from 1 hour to 2 means a lot of items writing, a lot of test arrangement, a lot of test execution efforts. How much benefit we get out of this tiny increase from, for instance, from 0.86 to 0.89 to 0.91?
Yes, I got.
What is the educational significance of that?
It's impossible to do.
But what is the educational significance of it?
You'll take better decisions.
Okay.
For example, certification examinations, like you have in Saudi Arabia or in the US, National Board of Medical Examiners, they really go to 6, 7, 8 hours of testing time, because this is a very, very, very high stake decision. So they don't want to take errors, and therefore they, they assess for a very long time. But it's very costly. It's very time intensive, and in a normal educational practice, like a normal medical school, would be impossible to do. But you have to realize the consequence that most of our methods of assessment in actual practice are not very reliable, and therefore you make a lot of pass-fail decisions, pass-fail errors. So I think that is the educational value of it. We realize that with every decision that you take, you have a lot of false negatives and false positives. One of the reasons that I take away the decision-making from individual assessments in programmatic assessment, because individual methods of assessment are not so well for taking those decisions. Correct. Be very careful. It's the same as if you would prescribe something for a drug for the rest of life to a patient based on a single measure. You don't do that.
Correct. My second question, you mentioned about the assessment literacy. Now, you see, most of the things that you're talking, well, trust me, not many people who are teaching will even understand the language of it, let alone the practice of it, let alone the practice and philosophy of it. So how do you face this? How do you come across this difficulty, and what kind of methods you have to facilitate teachers and administrators here to learn this?
Faculty development, faculty development, faculty development, faculty development.
difficult to achieve.
Yeah, but I'm not a clinician. What's your background?
I'm a clinician come medical educationist.
Okay, and what's your clinical background?
Well, as a general practitioner.
General practitioner.
Not a specialist.
Right. I'm an educationalist. I'm not a general practitioner, right? But
okay,
I will not dare to take over your patients tomorrow as a general practitioner because I'm not prepared for that. Yet in teaching, once you graduate, you can start teaching, but you're not prepared for that. And I think that just like in medicine, we want to use evidence and base our clinical decisions on evidence, evidence-based medicine. Why don't we do the same in education? Why don't we use some evidence in education and apply it to the educational situation? So I think people need to develop staff development.
Thank you, sir.
Thank you so much. Yes, Dr. Hassan Darami.
Thank you very much. I just have a quick questions. Through your journey, Dr. Case, the most challenge in order to shift it to programmatic assessment, the student, to the faculty, or the system? Thank you.
All of them.
Thank you. Similarly expected.
Yes, Prof. Al-Bagir. Prof. Al-Bagir, you raised hand. There is one question in chat box that can you please provide us any link or name of software of electronic portfolio?
Yes, we'll do that right away. Where's my chat?
Yes, Prof. Al-Bagir, you can unmute and ask your question.
But there are many more systems. There are many more systems.
Thanks a lot. Thanks a lot, Professor Case. I really enjoyed your presentation. I think it's just a reality in life that no one system is perfect. So I think it depends on first your setup, your geographic location, your culture, your type of students, and your curriculum objective.
Yeah.
Let us say based on a skill based or just competency curriculum. So I think, in my own view, we apply a kind of hybrid assessment method that combine a lot of assessment methods, reaching the most perfect one which can really help us to apply our objectives. One question is, I'm just talking about the OSCE exam. Does the validity and reliability ever changes or different from, say, when using simulators or when using real patients? Because I prefer to use real patients, but if you have, say, a class of almost 400, it might be difficult to have real patients most of the time. So sometimes we use simulators.
As far as I know the research,
yes,
it doesn't make much of a difference.
Really?
Yeah, it doesn't make much of a difference. I think what is important for OSCEs, I mean, the original OSCE had very short stations, right? And had very fragmented skills, like examination of the knee or blood pressure taking, right? These were very basic clinical skills. I think what is important in more modern approaches to OSCE assessment is to make the stations as authentic as possible, mimicking clinical reality as much as possible. And if you need 10 minutes, you need 10 minutes. If you need 15 minutes, I mean, you need 15 minutes. I mean, try and do a psychiatric interview in 5 minutes. That's almost impossible. So that's not, what you should do then in an OSCE. Make the stations as authentic as possible. And then still, the OSCE is a simulated setting. It's not the real setting, because in the real setting, I have to deal with patients. And there, I need some feedback. There, I think that it's important to observe, assess, and give learners feedback all the time.
Yes, right. But on the other hand, you need to have some abnormal findings. In simulators, there are no abnormal findings. It's just skill performance only. In real patients, you have a chance to have abnormal physical findings and to assess
That's
the
true.
student in a better way.
That's true.
In Khartoum, in Sudan, University of Khartoum, we use real patients in spite of the hustle of getting the right patient to the right station. But still, we strive to do this, and we believe having real patients as far as possible will be, in my own view, will be a better assessment than having just a simulator.
Yes. Yes, Dr. Nada Hassan.
Hello, thank you so much, Professor Kes, for your elegant lectures. I just want to reflect two of my experience. One of the experience is working with Arach University, where there is a portfolio and progress and everything. Regarding the progress test, I think the student find a way through the progress test, because they make like a peer group reading, and they tend to memorize the questions, and different passages they start to read together, and they start to score high marks. I don't know if this will affect the test regarding it is reliability and validity. This is one. And regarding the OSCE, we had again experience in Sudan, as the professor just before me. We have it with the real patients in a setting of OSCE, similar, around 10 minutes, but it's not a fragmented OSCE as you mentioned, but it's a real cases in which there is a systemic checklist for all the items. For example, a respiratory examination, it has to be complete, where more weight is put, for example, on percussion, if it is a target technique, but it's still the sequence of the test is maintained. I just want to reflect these two experiences. Thank you so much.
Well, thank you. I think that, yes, students will practice progress testing. And in our case, every new progress test is completely new. There's no point in memorizing old questions, because there's not such a question in the new progress tests. So that is pointless. We've done studies looking at the preparation of students for the progress test, but they look at their notes, they make a few prior progress tests to practice themselves, but that's it. Nothing, let's say, dramatic.
Thank you. There is one question in chat box by Dr. Salah. Is there research evidence for better outcome of programmatic assessment over traditional assessment?
Well, the short answer is yes. And the review paper that I was referring to summarizes all the evidence so far.
All right.
And I would actually encourage you to go to my personal homepage, go to publications link, find the publications on programmatic assessment, and you'll find a number of papers, but the review papers there as well.
All right. Thank you very much to all of you. Thank you very much, Prof. Case, for wonderful presentation. It really gave us an insight that what actually programmatic assessment is and what are new trends in assessment. And now this is the time to develop faculty development, so that we are ready to take this challenge, because it's linked with a lot of challenges. Before we close our webinar, any comments, any remarks from participants? And I'm so delighted to see so many international participants and local participants from Saudi Arabia. Thanks to all of you to join our webinar, join SESMI Riyadh. Any remarks before we end our meeting?
Dr. Shadia, if I can say something?
Yes, please, sure.
Dr. Shadia, I must say that thank you very much for arranging all these sessions. I really appreciate your effort and your dedication, your commitment to the medical education. I'm very delighted to see a young girl like you having this enthusiasm and arranging all these learning sessions for you. Thank you very much for that. God bless you.
Thank you so much for your wonderful words, and they means a lot to give energy and probably a young medical educator. Thank you so much. Thank you.
Well, thank you so much for having me.
Yeah, thank you, Prof. Case, I would say for your time and efforts, and hope to see you some other session and wherever we need your guidance while we implement it at medical schools. Yeah, thank you very much, and goodbye to all of you.
Thank you very much.